You're listening to the Physio Matters Podcast in association with Choose Health, and this is session 22. Welcome back to the Physio Matters Podcast with me, Jack Chew. Huge thanks as ever to all those sharing our previous podcasts, especially session 21 with Dr. Bronnie Thompson, who was expertly interviewed by my hero, mentor, and banter nemesis, Rob Tyre. This month's podcast is, for me, quite possibly the most important episode to date. Its title, maybe on the surface, might appear obscure and niche, but instead I consider the topic a fundamental underpinning of everything else that we've ever discussed on the last 20 plus hours of Physio Matters ramblings. Today's guest, Roger Kerry, is not only a leading author, academic, blogger and speaker, but in my largely biased book, a leading thinker in the field of musculoskeletal medicine and the philosophy of science. In this interview, I punch way above my weight and try to elicit some of Roger's wisdom on the tricky topic of evidence-based practice, clinical dilemmas, and medically unexplained symptoms. Stay tuned for a big revelation at the end of the interview in which Roger reveals a glimpse into his professional future. Apologies for the sound quality through Roger's microphone on our first few exchanges. Roger insists on having his office hoovered every morning in keeping with his diva-like lifestyle. So let's get to it. Hi Roger, would you like to introduce yourself and the topic for us all?
Good morning, Jack. My name's Roger Kerry. I'm a physiotherapist at the University of Nottingham, which is in Nottingham in the UK. It's a pleasure to be talking to you once more. This topic, we're going to talk about medically unexplained symptoms. Now, I'm sure we're going to define what that means in a minute. So this is it is slightly unusual. It comes off the back of a main interest of mine, which is in the philosophy of science and causation and how that applies to the evidence we use in physiotherapy. So hopefully there's going to be something very useful to say about physiotherapy in clinical practice.
Well, yeah, you'd think so. I mean, the last time we spoke was for an iPhompt podcast regarding the conference, etc. And so this is a little more of a tricky topic.
Yeah, it is. It's not a direct commentary on how to do something in clinical practice. It's much broader than that, but it's a different discipline. It comes from a different discipline. It's thinking about the way we undertake evidence and thinking about how we use evidence and thinking about that relationship with clinical practice in a broad sense. So it is a little bit more tricky, and I hope this translates well and it's of interest for the listeners.
Our listeners have had podcasts before that have been narrower and broader, so I'm sure it'll go down a treat. So the title, as we've said, medically unexplained symptoms, is somewhat more ambiguous than, say, core stability or the rugby shoulder that we've had before. Shall we first then try and define what that is, or an insight into what might be considered medically unexplained symptoms?
When we use the term medically unexplained symptoms, it's an established term in the medical literature and the philosophy literature, and what it essentially means, it's grouping those conditions that are seen in healthcare, that where there's a demonstrable absence of an explanatory pathology. So it's the conditions that we can't really explain from our normal pathological mechanisms. So typically that would include lots of complex chronic disorders, which can range from anything from chronic fatigue syndrome to irritable bowel syndrome, fibromyalgia. But for us in physiotherapy, I think a lot of the stuff we see would fall under this umbrella term as well. So typically non-specific low back pain, which is an example we've used before. So defined by a demonstrable absence of an explanatory pathology. That's what we're talking about. So when we use the term medically unexplained symptoms, that's what we mean.
I see. Okay. And so, as you say, an awful lot of, or an increasing amount of the things that we'd see in physiotherapy practice would fall under that as chronic illnesses and ailments without known specific cause increases across society. So we don't necessarily need to give specific case studies to make examples of this, but if we were to say something was medically unexplained chronic low back pain, for example, how does that present a challenge to how we've come to understand things, especially when discussing this with other, say, medical colleagues who want to try and find answers?
Well, the challenge comes from the shop floor clinically and from the evidence base as well. In terms of discussion with other medical colleagues, I think we're all having the same problems, although different people see things differently. So if we accepted, say, low back pain, chronic low back pain, non-specific low back pain, if we accepted that as a medical unexplained set of symptoms, and then tried to translate that to an orthopedic surgeon, for example, there are going to be challenges, because that person will be looking for certain things, and they might be working within a model where the surgeon believes that the disc is the cause, is the explanatory cause of the symptoms, and then we're saying, well, actually, we don't think it is because of X, Y, Z, and we meet those challenges every day, and you've spoken about those, and we see stories of those every day. So on the one hand, it might be easier for us to acquiesce and say, okay, maybe there is a biological explanation, and then what that leads us to is thinking about the research evidence we've got in this, and so say at the moment, our research evidence, if you took a really good look at it, as many people have done, and said, no, you can't, there is no consistent biological cause to this, the disc isn't the cause of low back pain, that is wrong, then we either accept that as a success of the evidence or a failure of the evidence. So it could be that the research evidence undertaken so far has been really good and failed to find a cause, and that's where we are. Or we can say the research evidence so far has only done so much, and the cause is still out there. It's just that we just need to look harder, and maybe next week we will find that the disc is...
Okay. Yeah, I see what you mean. When say medically unexplained symptoms are starting to be discussed, it blurs the lines between the categories almost required by a traditional format of evidence-based practice, so identifying a subject group to be studied. Does that present a further challenge in trying to actually get what everyone craves, which is this RCT gold standard that can then be reviewed in future?
Well, yeah, I mean, this is one of the core points, at least for me. We had this paper published about this a couple of years ago, and I think that this was one of the points we were trying to make. We're at a time now where we either accept that, like I just sketched out before, we accept that, okay, we keep close and adhered to our methods of inquiry, our research methods, and we just keep pushing and searching for this cause in that framework we've got, and within the ideas we've got of what science should be and what evidence should be, and we keep breaking things down and looking a bit different and conducting a better trial and a better experimental study. Or we say, wait a minute, this might be a real signal in the history of philosophy of science that the methods we've got so far don't really match the real world that we're looking at, and medically unexplained symptoms and the categories of health conditions that fall under that will never be explained, will never be further understood by our current methods. So we need to re-establish what our underpinning philosophy of research and evidence should be, and find other ways of exploring this phenomena.
And so is there a fear that it's gone too far that way in order for people to back off and accept that? So there's a whole industry has been formed around chasing that dream almost. Is that a worry?
It is a bit of a worry. I don't want to say that we've gone too far down. Presumably you're talking about things like the traditional methods of research, randomized control trials.
Yeah, I sort of mean that there's academic institutions or groups or funding streams in which they will exclusively go under the research methods that have been long established in medicine and other pharmaceutical industries, and we've tried to extrapolate that into our manual therapy interventions, even exercise interventions, to try and identify what would benefit certain groups of people. So I'm just wondering, as that has expanded, has it kind of gone far enough that it's hard to back away from?
I think it's a desperately important point that you've said. One danger here is to fall into the trap of becoming anti-evidence-based medicine, anti-evidence-based practice, anti-RCT, and that's not the case here at all, at least where I'm coming from. I think certain methods suit certain scientific and clinical questions, and within that we can be even more specific about what questions methods suit. So, for example, the randomized control trial is a phenomenally valuable tool for certain questions.
Yeah.
You're talking about extrapolating that to more complex situations, and there are supporters of that. And if you read or listen to someone like Ben Goldacre, he would say, most things in life that we need to understand whether there's some sort of causal association with, a randomized control trial is fit for purpose. So complex interventions, economic interventions, educational interventions, it can all be suited to investigation with randomized control trials. Other people, and I probably fall into this camp, would say that there's a limit to what the knowledge we can draw out from randomized control trials, and you start to reach that limit when you start to border on complexity and context sensitivity, and medically unexplained symptoms are coming under that. So this isn't a matter of dismissing any particular research methodology. It's more a matter of matching research methods up with the clinical concern that we happen to be interested in that time.
Right. Okay. Now, and that's landed me on something that, correct me if I'm wrong, but I feel that in some ways you've been misrepresented a little in the past in people using some of the work that you've done in which you contextualize what evidence tells us and what it sometimes doesn't tell us, and the idea around different methods for different things. I've had people put things under my nose with your name on them, suggesting that we can almost ridicule the current evidence base or to blanketly refute some of the things that it says, which does sometimes open a door to certain mavericks selling pseudoscience. And so I understand that's certainly not how I understand what you've been promoting. Is that am I right in that misrepresentation? Do you feel that does occur?
Yeah, it's a real risk of challenging the current state of evidence-based medicine. For example, it is a misrepresentation, absolutely, and I'm glad you can see through that. So this, as I say, my work on this is certainly not anything to do with being an anti-evidence-based medicine, anti-science. In fact, it's exactly the opposite. That this is pro-science. As I said earlier, my interest is in the philosophy of science. It's how we develop better science to answer more and more complex questions. What I've said before is there are many cases where we look to establish causal association. So we might look at randomized controlled trials, but there are so many problems within those methods for that clinical question that it's erroneous to say, so this intervention works and this intervention doesn't work because I read it in a randomized controlled trial. Life isn't as simple as that. And I think it's another example of how easy it is for a discipline like physiotherapy to take the pendulum completely one way or the other. So if somebody's saying something that is supposed to be in the middle ground, it's easily misinterpreted. You don't believe in that, therefore you must be anti that. and it's completely swung the other way. And that's not the case at all. I'm really interested in the methods we use. I think the development of experimental methods in randomized controlled trials has been one of the most innovative scientific processes in the last century. It's an amazing tool to answer certain questions, and systematic reviews of high quality randomized controlled trials for certain interventions have saved countless lives. There's no doubt about that. But there's a limit to what that tool can do. And
absolutely, yeah.
See that limit very clearly all the time.
Yeah, and medically unexplained symptoms is such a perfect example of that, which is why this conversation can sort of naturally drag us towards evidence, which we don't want to go down that rabbit warren too much. But I think before we start to delve into some of the other parts of those papers that you've mentioned, am I right? Am I okay to sort of say, what's your understanding of how causation can be best described in terms of you've said interventions working? I've seen, particularly on Twitter recently, you've posed the question, what do we even mean by the term something works? Where are we at with the causation literature in both philosophy and your musings with physio?
I think we're at a really interesting time. That question was supposed to be provocative. It seemed like you could read that as a deep philosophical question. You could read it as a real life shop floor question. What I meant was more towards a shop floor question. If you've got a patient in front of you and you're ready to intervene on that patient after assessment, there's a binary decision you've got to make. You either do something or you don't. We can talk all day about, well, it might work, it probably work, but at the end, you either do something or you don't. Or if there's two interventions of choice, you either do one or you don't, or you do two and you don't do three. Everything's a binary decision at that point. And within that decision, there's got to be some concept of belief in that it will help somebody, it will work. And what I meant was, what do we mean when we say that? And in the bigger context of evidence-based medicine, there are tools within evidence-based medicine to help us understand what works. Again, systematic reviews of randomized controlled trials of interventions are aimed at establishing causal links. By causal, I mean work. So work is a causal term. That's all I mean. It's you're talking about causation there. So on the one hand, we can get our causal knowledge from randomized controlled trials, and then in the clinical situation, then we could either say, okay, what I mean by this will work is that there's systematic reviews of randomized controlled trials that says it works. And then I would say, is that the same thing? We're looking for the same it works thing in our single patient that we established from randomized controlled trials. Now, one response to that, which I'm and the group I've worked with are thinking is it's not the same. In randomized controlled trials, you establish causal links in a certain way. You establish it in a group of people, and it's based on a statistical model, which will give you an average output of that population, and that's based on a very particular and specific philosophical underpinning. And what I'm trying to say, the work we're doing at the moment is saying that philosophical underpinning isn't fit for purpose for the single instance with the patient. It can inform that, but the patient has got more to offer to that decision-making process than just a simple translation of the causal association from the trial to the shop floor.
Right. Yeah. No, that certainly makes sense. Now, off the side of that, really, when we talk about medically unexplained symptoms, because of the increased need for us to try and identify how to best manage these things, the almost holy grail of any research or any evidence that comes through would be if they found something that works for that category of patients, if we were going to say that it's a category. How will our understanding of causation better influence our decision making in treating people with medically unexplained symptoms, do you feel?
So the alternative understanding that we're trying to work on for causation comes from the shop floor. It's about establishing what works with the patient. So But to do that needs a refinement or a reconceptualization of the philosophical underpinnings of causation. Now, I don't think right now is the time or place to go into the depths of that. But let's just say causation is something to do with the interaction of the therapist and the patient, which can be informed by external evidence. But there's some philosophical work needed to re-establish what we mean by causation. To put it into the best lay terms I can, we should think of causation as something that is multifactorial, is complex, is context sensitive, and it changes all the time. So if we're working with a patient, there are different causal processes that are changing all the time, and the patient is the only source that we can understand how those processes work and how they should interact. Now, so let's take the biopsychosocial model as a starting point.
Yeah, because that was going to be where I dragged that question almost, is that many, including me, have championed the biopsychosocial model, suggesting it being a step towards patient-centered holistic care. And in some of your recent work, you and your co-authors have an interesting take on its shortcomings, which admittedly there's been many more championing it than criticising it. So what's your take on that, and how does that influence our decision making?
Absolutely. So once again, let me state here that this isn't about knocking anything down. It's not about saying you could see a pattern here where something comes up and I just knock it down something.
Well, that's certainly what giving you platform to defend that. It's a frustration of mine when I see that done, because of course everything should be open to critique, and so nothing should be held too dear that people get too protective over. So many people being defensive over certain things. So you've certainly justified that in your papers. So, but there's an abundance of long words in those papers that we might be able to extrapolate to the coal face, if you will.
Right. Well, hopefully this is a good opportunity to do that. I think you've summed it up before by saying things like, the biopsychosocial method is the best we've got with dealing with complex. So we're talking about pain now. Let's take pain then as the medically unexplained symptom, what we're talking about now, because that fits well with the biopsychosocial model. But on that point, there's some challenges to this that we could come to later as to whether pain is a medically unexplained symptom. But so let's talk about biopsychosocial model. Best of a bad bunch, call it what you like. It's again a game shifting move that began a few decades ago that we're really starting to embrace, and we should be, because it's the best clinical model that we can look at. My conceptual approach to life generally, and to my work, and particularly work in philosophy of science, is that's absolutely fine, and we should look at all the great things that are coming from that. But the way history works, and the way science works, and the way progress works is, you don't just say, right, that's it now, we found it, this is okay, it might be the best of a bad bunch, but it's good and it's great, so let's take the foot off the throttle and we can all relax. Each phase of development is just a signal towards where we're going next. So I think the biopsychosocial model is a phenomenal clinical approach, and it's a signal towards better ways of dealing with complexity. And in this case, chronic pain, it's not necessarily the answer. So all we were saying in that paper is, okay, this is showing some good ways forward, but if you break it down, there are still problems with this framework, model, approach, whatever you want to call it. So that's the first sort of thing we were saying. This is good. It's starting to help deal with complexity, but there are still limits to
the so it's something that it's on its way. It's definitely a step in a direction, we would argue, through what we understand of the literature, to be a step in the right direction. However, the idea of taking our foot off the gas and thinking we've found, or even somewhere nearer to, an answer isn't necessarily the way in which we need to understand science to better serve our patient.
Exactly. Now, the way we sort of critically analyse the biopsychosocial approach is quite simple. Because so if you think about what's happened here over time, we had the biomedical model. During that time, we've got the development of better research methods like randomized controlled trials, better mechanistic studies, and we start to understand that the biomedical model is insufficient for complexity like pain, and then some clever people or a clever person sat down and thought, well, there's let's think about this in a biopsychosocial way. So we suddenly had more dimensions to the complex phenomena, and that starts to develop with thought and work, and eventually starts to be tested in trials. And we're now at a point where, yes, this biopsychosocial model is better than the biomedical model in explaining and addressing complexity. Now, the problem comes, and it's back to this idea of limit cases of the research approach, the general research approach, is that although the biopsychosocial model sets out to be more holistic, it's not. By definition, it's the opposite of an holistic approach, because all it's doing is breaking the patient down into three components. It's reducing the patient into a biological, a psychological, and social component. So it's still falling foul of some of the reductivism that is seen in the traditional approaches. So it's trying to be holistic, but it can't be because of the underpinning philosophy of the traditional research methods. So what we need is a truly holistic philosophical underpinning for something like the biopsychosocial model to fit in.
Yeah, I mean, and I certainly wholeheartedly agree with that. However, on the front line, which we'd said we were always going to drag it back to clinical, it is often seen as a step in the right direction, and so it's been and is still a fairly tricky thing to try and extrapolate into frontline practice, is the idea that taking something from a biomedical finding of answers to something a little broader, which is the biopsychosocial model that incorporates and understands things and the interplay between systems, that's already pretty tricky. So to expand it as much as we would ideally like, and start to understand philosophically about just how broad this can be, truly holistic care, it feels to me on a clinical level that seems quite distant. So my fear that I pose, and see what you think to that, would be that if we were to have the likes of your group, or if the research was to take a truly holistic philosophical approach to causation, to research methods, to how we best understand how we interact with people, if that leaves behind the clinical practice, then my fear would be that that gulf that can come will mean that, again, mavericks thrive.
Yeah, your fear is absolutely warranted there, and I feel that as well. And a couple of ways for me to address that are, firstly, I don't think it's entirely helpful to think of what we're both doing here and what the world's doing here as one simple linear pathway. So there's clinical practice, there's research evidence, and there's the thinking about all of that. And let's think of those as three sort of levels or dimensions of life. Clinical practice can go on and on and on, day by day, being informed by research and by critical appraisal.
Yeah.
But research and critical appraisal and critical thought should, to an extent, be allowed the freedom to continue doing what they do without necessarily there being an absolute clinical implication at every single step. So it's really difficult, and it's wrong for me now to say, we started thinking about this, so when your next patient after lunch, do this, because it doesn't translate immediately. Interestingly, there's been a really nice Facebook discussion on this recently, where I tried, to make this case, and it's, as you know, social media is the place to be continually challenged about your thoughts. And there's no doubt about it that most critical thinking shop floor clinicians come back and say, well, what are the practical implications of this? Well, it's really difficult to say right now. And that, again, is how science works, and it's how the history of science and it's how the philosophy of science works, and always has worked. So throughout the history, there are countless examples of abstract thought that looks really difficult to translate to clinical practice, and nothing like what
Yeah.
there comes a time when things start to come together. And the case I always like to talk about is the abstract notion of imaginary numbers in pure maths. So there was a time when pure maths was seen as a pure folly, and it had no practical implications, and probably still is by some. And imaginary numbers is part of the discipline of pure maths, and people worked on this notion of imaginary numbers, and the whole world went, this is ridiculous, there's no practical implications for this, you're wasting your time, you're wasting your thought. Then suddenly it becomes apparent that in order to achieve a consistent electricity supply, a circuitry related to alternating current, which we need for all our electricity, you have to have the notion of imaginary numbers. Without that, we can't have electricity in the way we have it now. We can't have AC/DC circuitry.
Right.
So, and that, that's just one example, and that's how science works. You need to research, and critical thought needs to progress independently of clinical practice, with the ultimate aim of informing clinical practice, but you can't always see that on a day-to-day level. Now, I'm not making an excuse here to say, well, the reason my work isn't clinically applicable tomorrow,
because it will be in several years' time.
Yeah,
No, but I can understand what you mean, because in the next breath, you're explaining that you want clinicians to engage in frontline research and to understand the variety of methods that we can influence practice with. Is that right?
Exactly, and more importantly than clinicians, patients as well.
Yes, yeah.
What we're coming to here is the conceptual change in the way we think about evidence. And can I just give a big shout out to Trish Greenall here, who's as far as I'm concerned, and she might disagree with this, is of a similar mind to me. And the recent paper that's just been published, which was the 6 biases of evidence-based medicine, she also points this out, that we've got to a stage over the last 20 years, we've put research at the centre of the evidence-based model, with good and honest intentions to include the patient within the development of research, and we've missed a trick, not on purpose, but because of the motivations, and like you said earlier, because of the enthusiasm and the research funding and the intuitive appeal of those methods, we design good research, and we involve patients in that, and we involve clinicians in that. But we're looking at it the wrong way around. The research should start with the patient, the therapeutic relationship driven by the patient and the patient narrative, and the patient defines the language and the patient defines the questions, and then our research should relate to that. So that statement might seem like, well, yeah, that's very good, and I think that's what evidence-based medicine has always tried to do. It's not done that at all, and it's moving further and further away from that. And the more we study populations, the less we study patients. So what Trish Greenall is saying, what we're saying, but from slightly different viewpoints, is that coming back to pain and medical unexplained symptoms, and the way we undertake research is that we start with the patient. We start on the shop floor, and everything is derived from there.
Brilliant. Yeah. Well, I mean, I'm, if you don't mind, I'm going to park that for a second and come back to the sort of the way in which we can engage the patient, and what problems that might lead to. But just to put some meat on the bones of what we're talking about with regards to the almost innate intuition to try and categorize things, because especially the symptoms and the available treatment can sometimes mean that people naturally want to stratify care. It's particularly trendy in all sorts of different divisions, and in medically unexplained symptoms, we could argue that even to give it that label makes it a category in itself. So in doing so, how can we best plead with people's logic to change their perception and to not naturally want to try and put people into boxes or to identify certain responders and non-responders to things?
This is a huge challenge because nonetheless, because this is the nature of our nurturing, really, in education and over physiotherapy and in medicine and evidence-based practice.
Absolutely, yeah.
30 years, we've been more and more. And for me, who on a daily basis critically tries to think of this and produces work to challenge this, I still feel, me personally, it's really difficult to move away from those thought processes. What you said just in that question there sort of hits the nail on the head, is we're continually searching to relate an intervention to a set of symptoms, or a patient with a set of symptoms. And that's the crux of it, really. That search to relate the same cause to the same effect for the same set of symptoms is where we're going wrong. That's what current methods of research are focused on, to look for the invariance in a complex world. What we need to be doing is accepting that there probably isn't an invariance and everything is variable and everything changes. Now, problem with that, again, as you say, is, okay, so you're opening the way to all sorts of things here. Chaos will reign and anybody can do anything for everybody. But that's why we've got to find a good philosophical underpinning and a good research methods to tighten that up, but putting variance and the patient and the complex and context sensitivity of a patient encounter at the center of the world, and not the continual pursuit for invariance. Now, back to your point about stratified care, in fact, paradoxically and quite comically, this is where this is all going. And if you think about stratified care and the subgrouping of patients, what's happening is subgrouping is getting better, stratification is getting better, we're subgrouping more and more people into more and more subgroups, and that trajectory will carry on until we get to the ultimate subgroup, which is the single patient with their own collection of signs and symptoms, which is different from the next patient. So
would you suggest that stratified care is an essential step towards individualized care?
Well, that's quite a question.
Yeah, sorry. I mean, of course, I don't need you to say yes or no to that, but just, I found myself through interviews with our podcast guests, and also when I'm trying to lead workshops on this, and even at the Physio School in Nottingham, when I've delivered lectures there, just discussing the innate desire to stratify and categorize is something like you said, it's ingrained in our education system. But I try if I can to make a case that on the clinical front line, distancing from subgrouping to at least a formal extent is the better way to go to chase true holistic care. Now, from what you've said, and I understand the flip side case, is that can we get there without smaller and smaller and better defined subgroups? I wondered if you'd mind just musing on that.
Yeah, this is probably an oversimplification of the world in response to that, and a bit of a cynical comeback to what you just said there, Jack. So it could look like this. 20 years ago, 30 years ago, 40 years ago, whatever, we did such and such, and it was all messy and it was all wrong, and it was all based on clinical opinion and expertise and fraught with the problems of human biases, and everybody's making decisions left, right and centre. Then it's all starts to get tightened up, and human biases are put to a side and de-emphasized, and priority is given to methods with less bias, and we start to shape things up a bit and understand the world a bit better, and blah blah blah. And we went off on that trajectory, and within that trajectory it's all about identifying these causal relationships, and at first it's in big groups, and that's not good enough, so we subgroup it and we stratify and we subgroup and stratify, blah blah blah, and that's where we're going on. And the cynical view, and this is something, this isn't just me saying this. It's I do have a lot of respect for this view, but it's not just me saying it. And in fact, Gwen Jewell made a keynote lecture a few years ago. I think it was at WCPT or IFOMP or somewhere, where she said pretty much the same thing. Eventually we're going to subgroup down to one, and basically be where we were 40 years ago, but we will be better informed in lots of ways. But essentially, we're still making decisions based on the individuality of each therapeutic encounter rather than being informed by population studies. But it's taken a long way to get there, and we've gone through this really long journey of epidemiology, population studies, stratified subgroups. And in fact, what I might say is a really cheeky, cynical comment is, we could have got there a lot earlier if we just revised our philosophical underpinnings of what we mean by research and what we mean by patient-centered care, or better still, not patient-centered care, person-centered care. And we could have got there decades earlier if we'd thought a bit harder.
And then the flip side being that we wouldn't know that if we hadn't have made the mistakes, I guess.
Exactly. So it is a silly situation. It's a silly commentary, but I think it is the real world view. That is where we're headed. So I suppose in a more realistic, direct response to what you asked there, then maybe this journey was necessary. Maybe in order to get to true person-centered holistic care, we needed to go through this process. But when you step back and look at it from a sort of broader philosophical critical view, you say, well, it could have told you that 20 years ago.
Yeah, absolutely. And in your paper, of course, we'll be making the resources available for the listeners. There's a really nice section in which you outline the idea in which certain specialists will see the symptoms related to his specialism. And so explaining that a rheumatologist would identify inflammatory factors, a neurologist, the neurological factors, etc. And it sort of struck with me at the fact that with regards to this being the Physio Matters podcast, granted we do have a variety of other disciplines that listen on a regular basis, but it made me sort of wonder, are we well placed as physiotherapists to try and draw on all the different specialist levels and try to make it as person-centered as possible? And if we are, and you've blogged on this before, is that there is still a bit of a reluctance to think as deeply as we're sort of trying to discuss. And the idea of applying all these multiple factors to clinical reasoning is somewhat intimidating for some. So what do you think of that?
I think physiotherapy is absolutely ideally placed to be the leaders in reconceptualizing our understanding of complex conditions.
Right.
As you said, it's already started to happen.
Yeah.
There's glimpses of it. It hasn't been explicit, but when we step back in another 10 years and look, we will see that the likes of Lorimer Moseley, Pete O'Sullivan, even Adam Meakins, if you look at his approach to the shoulder complex, he's glimpsing on what I'm talking about, and his strapline of complex doesn't need to be complicated, sums all this up, because ultimately, although both of us now, Jack, could keep alluding to this mysterious future that I'm sort of pointing towards as being really multifactorial and messy and complex, it's not, because what we're searching for in true holism, what would happen is from a lot of complex parts emerges a single phenomena which needn't be complex. So back to your thing about the rheumatologist, the orthopedic, blah 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 blah. It's the old 6 blind men and an elephant.
Yeah.
You're reducing the complex phenomenon to all these different things. Everybody's got a different opinion. And no, it's this. No, it's that. No, it's that. We see this all the time in physiotherapy. And you reinforce that state of mind with a reductivist view of the scientific world. We keep reducing things down. We step back and took a view from the other side of it, and looked at something truly holistic. We would look for things that are emerging from the commonalities of these individual things. So rheumatology says this, orthopedic says this, the neurosurgeon says this. But look, can you see there's this common thing that they're talking about? They're all talking about, but they don't know they're talking about it. And this is the emergent thing. And I think that's what we can see as physiotherapists. And I think people, like Louis Gifford, has seen these things, and Laurie Moseley has seen these things. Etc., etc. Now we're at a stage where we need to say, right, look, something different is happening in the world here than we thought it would do. And there's no way the rheumatologist is going to change, because that's his job. There's no way that this guy's going to change, and that's fine, because they do great work in all sorts of areas. He says in a really patronising way.
No, but I do certainly see what you mean there. But I feel that me and you have got to be honest with the listeners and with the way in which we're discussing this topic, is that there will inevitably be some people that have already switched off from this, and there'll already be some people that listen to the whole thing, try to interpret it and think, well, what am I meant to do with that tomorrow compared to shoulder instability, or compared to the discussion that I had, say, with Greg Lehman about biomechanics. There's concrete things that they can then implement with their thinking and their practice. This is a bit broader than that and deeper than that, and there is some obvious reluctance for people to at least think on this level and to scrutinise not just their practice but themselves in the way in which they construct thought. And it bears the question, like, are we paid enough, respected enough, or given enough credit for what comes of it to actually engage with thought on this level?
It may be that, for the clinician to make the most of progressions in science and philosophy, they just have to wait until a time when it can be easily distilled. What I would say on a day-to-day basis now is for clinicians to, if you're already working towards a broader mind approach within the psychosocial model, just keep churning towards that. Listen to what Greg Lehman says. Listen to what the pain people say, but don't dismiss anything else, and certainly don't miss the patient. Place the patient at the centre of your clinical examination and management program, but think of that patient as a person, as a human who's relating to the world in a certain way. Don't try and break down each specific component of that patient. The examples are there every day. Here's somebody with non-specific back pain. He's got a stiff back and tight muscles. They aren't anything to do with this phenomena of pain. They probably don't need addressing. There is something else going there, and that's what a model like the biopsychosocial model can teach you. So clinically, carry on doing that. But in the future, there's even more potential to take a much more humanistic view of that person who we call a patient.
For sure. And truly putting them in the centre, although not simple, is the only way to truly simplify and for us to directly address the concerns of the people that present to us. So no, I completely understand that. That's great. Now, in the last, to bring it, although I would never say we've gone away from medically unexplained symptoms, because this is an important conversation that has to be had about it. But in the last decade, this increasingly loudly in the last few years, a strong and intriguing case has been made suggesting that medically unexplained symptoms could be accounted for by considering, say, processing faults, often referred to in terms of neurology. So the suggestion that sensations that patients feel can be somewhat misleading, and they certainly feel more dangerous or more troubling or more concerning than they actually are. Is this idea of us explaining those to patients and understanding them ourselves as faults, is that an improvement, or is it still reductionist?
I think we can choose what we want that to be, and that depends on how we frame that. So we can frame that in a very non-reductionist way. So the danger would be to reduce the patient's complex life experience of pain down to one simple explanation. So it could be part of it, and in the scheme of things, if we look at all the other parts of it, it's a very good part of it. It's one that's most supported by neuroscience and evidence. But back to the grand worry. I mean, people have written nicely about this, and Amanda Williams, for example, at UCL, sort of talks about this and makes the argument that actually pain particularly isn't a medical unexplained symptom, because you can explain it because of what you've just said there, Jack. But there's still a bit of missing the point there. You've still reduced a complex human phenomena, which we know is a complex human phenomena from decades of good scientific study, to one explanation. So it's like trying to explain consciousness through neuroscience, which you can do, but it's not really the explanation.
No, you only really knock on the door of consciousness by thinking of it from a neuroscience lens. You'll never get there. You'll never actually get to the meat on the bone, so to speak. Is that fair?
Exactly, but it is a part of it.
Of course, you can't be. But when just like, I suppose I can put it into at least a little, not case study, but if we were to say a patient, let's take it away from pain and say a patient is getting repetitive problems where they're presenting to, say, a GP with loads of rumbling in the stomach and just the fact that there's a variety of noises, sensations and unpleasant things going on where they feel disconcerted about the fact that they're getting these symptoms in their stomach, which are medically unexplained. So they go through a process in which things are medically cleared. If that was then explained in terms of, to some extent, not neuroscience, but just the idea that these sensations and symptoms are reassuringly not dangerous and that they're not necessarily a true representation of something that needs to be acted on, as long as that patient is driven towards a functional approach in which their whole being is considered and they're reassured on a level that means they get on with their life, that intervention working is probably what we're aiming for. Is that fair?
Yeah. I think that's a really nice example of what you just said. If that would work for that patient, if that therapeutic alliance that you've just spoke about there did do its job, you've approached that patient from a certain way and not reinforce other more aberrant things. So that would work for that. If you tried to conduct a randomized controlled trial on what you just said there, that would be almost impossible.
Yeah.
In what you said there in your case narrative was lots of words that didn't relate to medicine and didn't relate to health. They relate to a human, and that human's feelings of some rumbling in their stomach. And what we should focus on is that disconcertedness that person spoke about, is there worry that person spoke about. This doesn't necessarily need to be a true psychological approach. It's a life approach, and our job as physiotherapists is to improve people's function in life and in society.
Yeah.
And we're trying to improve that person's function by making an alliance with that person and addressing those humanistic dimensions of their life experience, and not reinforcing matters of biological matters of a rumbling stomach.
Yeah, no, that's great. And as you've said, the spectrum being that if you were to try and deal with that specifically with the biology, you'd come up short. Equally, if you were to deal with that specifically with the psychology or even the sociology, you would again come up short. So it's truly understanding not just the variety of categories or systems, but the whole person and what that means to them. So no, that's certainly interesting. So I've just one that I did that just popped up in my mind regarding rumbly tummies, maybe because I'm hungry. But the another one that I did sort of put together, which I want to throw at you, is just the idea of when a patient really does truly become lost, and how we can maybe best understand that. So. Let's say if the patient is at the center of all reasoning, if I use this as an example, a 35-year-old male patient presents to a physio, 3-year history of constant but variable knee pain. There's like a sensation of instability and episodes of clicking that occur at times. He's had 3 MRI scans, 2 Dopplers, 1 CT under contrast and 2 arthroscopies. Of course, I've made this up, but let's say he's been pretty thoroughly investigated, often by multiple medical specialties in which they think they've got the answer. There's 5 different professionals that have taken him down a diagnosis and a thorough plan and treatment that has sometimes helped briefly, but nothing has actually changed his ability, and he's functioning more impaired than he ever has been. The result of this, which is, I've just described a made-up case, but it represents an awful lot of my patients, particularly working in sort of tertiary care, second opinion, seventh opinion work. this man feels like an enigma. He feels completely misunderstood and feels that, if anything, he needs to be held as a medical case study because there's something going on with his body that no one clearly understands. Now, although, of course, this is I don't necessarily want us to come up with a specific treatment approach in this circumstance because we don't know the person, partly because the person doesn't exist. But with that in mind, how might we best start to reframe our profession or the system to better serve someone like this and to stop them getting into that mess in the first place?
First of all, the patient is absolutely correct. He is an enigma and he has been misunderstood.
Yeah.
Because he's been examined as his component parts, and the search has been based around the question of why. Why has he got these pain? Why has he got this instability? Why is this? And at one level that's healthy because if we know why, we can do something about it. The question should be really focused on what and how. What is this patient's relationship with his body and with life, and where does he position his experience of pain in his life, and how does that make him operate in society? He knows, at least in some sort of implicit way, that this isn't about a small biological finding on an MRI. He might explicitly want it to be.
Yeah.
He knows as a human that that's not what human is about. He's experienced a phenomena that's in direct contrast to what these medical authorities are speaking about. The two languages are different.
Yeah.
Again, if you look at what Trish Greenall said about the relationship between patients and research, it can't go on because the two languages are different. Human language is different to what we talk about in healthcare and medicine, and we try and bring patients down to our language, and really we should be listening to him. So he says he feels. Feel is a human.
Yeah.
An enigma. He feels misunderstood because he is. He's absolutely misunderstood because his experience of life at this point has been tried to be reduced to these certain things and built back up in the search for why is this happening, when really we should step back and go, what and how is this happening to this human being? Now, what would be really nice now is for me to say, and here's a little clinical sheet that you can do this patient. That's not what we're at, and it's not. It may be where we're heading, but if you think that you're sort of missing the point as well. Again, we should be spearheading this as physiotherapists. We're a unique profession, and we can absolutely lead the way on person-centered care.
One of the it's really, and the reason why I sort of parked it when we were getting into the juicy topic of why we don't put patients at the center of things, particularly research methods. And I said I'd come back to it, and it's because I knew that this little example was coming up, is that the danger and a fear that I sort of share with a lot of people really is that if we were to put the patient at the center of these things, so that means that if we were to try and identify what it is that patients would want to know and gather from the research that we then conduct to better serve society. I love that as an idea. However, we've already indoctrinated sort of through media and through misconceptions about what it is that people's bodies tell them and do and how their health should be lived is they're not necessarily well informed enough to inform us is one argument that gets bandied around. And so if we were to use certain new research methods where patients guided the process, would we end up probably chasing our tail a little bit in terms of trying to find things that patients want rather than what they need?
Well, again, that's directed by our underpinning thought or philosophy of what we mean by research. If you look at the campaign for real evidence-based medicine, this is exactly what they're trying to address. So we do need robust approaches. We need robust methods. But the vision is that that can be achieved with the patient in the centre, and with establishing real evidence that does filter out stuff that as no will only serve to hinder progress. So earlier you mentioned pseudoscientific approaches and voodooism and whatever. So there still can be robust evidence-based medicine systems that do that by putting the patient at the centre. We're not there yet in the campaign for real evidence-based medicine here, but that's definitely the way we should be going. It's a massive challenge.
Yeah, so then it really is truly collaborative rather than, although the patient can be at the centre of it, they're not alone in the centre of it, is what you maybe mean.
It isn't a matter of appeasing and acquiescing to the patient. The patient says, I want ultrasound, so let's do that because that's like a real holistic thing to do. That's not the case at all.
Yeah.
It's establishing really what we mean by the patient as a person, the person as a human, where we sit with our population data and bringing all these things together. The vision is there, the strategy is there, but we're only partway through that strategy. As I say, it's a massive challenge, but it's no more massive than the challenge was when evidence-based medicine emerged from epidemiology in the late 1980s. It's the same sort of challenge. It's just the next phase.
And something we need to embrace. That nothing changes without challenge, of course. And I think that one of the most common debates I do find myself having is that patient-centered doesn't necessarily mean pandering to patients, and equally evidence-based practice, or whatever we would suggest as being someone who's more research heavy in terms of their reasoning, it would suggest that they aren't being too patient distant as they sometimes appear. And so it's about, again, finding that middle ground and justifying things beyond basic parameters that we've already been taught, expanding our thinking in that way.
Absolutely, and that's a massive challenge to change that mindset of our education over the past 13 years. 30 years or so is a massive challenge. But we've got to be careful of people putting up straw men like, you're just doing what the patient wants. That's not what person-centered care is at all.
No, exactly. And there's plenty of occasions in which misrepresentation and straw men do appear. And I know we better wrap this up. Just looking at the clock, as much as I know we could witter on about this for hours on end. But one of the things that I did want to sort of pose to you, as cheeky as it is that having had this conversation, obviously getting to know you both when I was one of your pesky students through to now, obviously trying my best to understand your work and collaborating with you on a few things, is that I can't help but feel like all these chats lead me to think you'd make one hell of a physiotherapist, Roger. And as far as I'm aware, you're not necessarily doing any clinical frontline work and haven't in a while. I know you're a busy man, so I'm not trying to drag you in front of patients, but does that, I imagine, presents problems for you when trying to discuss research dissemination or discuss patient-centered care, when it's easier to talk about than to do sometimes. Is that fair enough?
You've got a fair point there. It is much easier to talk about, and you're absolutely right. There's no way I do as much clinical work as I once did. The clinical work I do is mainly based around consultations, although I'm starting to do more and get more interested in rehab work, especially in sports, and that might seem a sharp end of this, but somebody running along the ground is an example of a relationship between a human and life, and even biomechanical injury, biomechanical inverted commas, localized knee pain in a runner. It's, I see more than that, and Trish Greener will see more than that, and Adam Meekins will see more than that. It's not somebody with knee pain running along. It's the interaction between somebody wanting to engage in a certain way in life and their relationship with that life. And I love that phenomena. And approach the clinical problem from that way. And I'm at a stage now where I wish I could do much more than that, but I've got lots of photocopying and stapling to do. So
absolutely no. So that does open the door for you to come and do some clinics, some practice over in my clinics then.
Yeah, set them up. I'll be there.
Right, brilliant. As long as I can dragging you, kicking and screaming. Well, not kicking and screaming. Maybe you'd be keen to get more and more frontline stuff as we change the face of what we know of evidence-based medicine and make medically unexplained symptoms at least explained in some capacity. Is that fair enough?
That's fair enough. I'll iron my crimpoline trousers tonight.
Brilliant. Yeah, well, that's one thing that hasn't changed, hasn't it? Tragic physio uniforms. That's one for another podcast, certainly. Now, one thing that we always end on is the chance for you to plug any work you've been doing and direct listeners to any important work or certain people. I know you've name dropped throughout. So, is there anything specifically you want to mention on top of those things?
Well, I will mention that our current project, the Cause Health project, people Google Cause Health or one word, that we're at the start of a 4-year project working on this very thing that we've spoke about yet. First workshop is in Oslo in October. Keep an eye on that and we'll be producing stuff from that. The journals, a lot of interesting information is coming through for this sort of subject for me is the Journal of Evaluation of Clinical Practice.
Right.
Which has just had a special edition on this sort of matter. Social media is a place to be. Follow the right people, engage in the right discussions. You know all about that. And also, I think we're at a really interesting time. And big sort of shout out for Mick Thacker. He's starting to produce 1 or 2 little bits of editorials and written work that's putting a really nice little fly in the ointment of where we are with regards to complexity in the guise of pain science in this case. So read some of his stuff, and of course Trish Greenall.
Yeah, brilliant. No, we will definitely get some of those things you've mentioned out for our listeners on our newsletter, and make sure that everyone accesses those to put further avenues and layers to what we've just been discussing. So that's brilliant. So thanks a lot. Also, I know that we'll be catching up, I'm sure, if not before, at IFOMP 2016, which is something that we've been doing other smaller snippet podcasts for. But are you looking forward to that?
Yeah, absolutely. It's going to be a great time. So not far away now, less than a year away. We're all excited about it.
Exactly, yeah. We'll soon come around. So if not before, I'll see you then. Thank you so much for having a chat with me today about these things. I know it was a tricky topic for us to negotiate, but hopefully we've done well and that the listeners get something from it. But if people want to hear more from you, where would they find you on social media?
At Roger Kerry 1 on Twitter. Just my name on Facebook. Don't dismiss these things if you're not already engaged with social media. This is a really, really important platform for professional discussion.
Yeah, it's a funny one. We've got an awful lot of people that engage with the podcast on a regular basis that haven't taken that plunge yet, and we get emails sometimes explaining why and that they're affording the time for one thing at a time. So hopefully we'll tempt more and more people towards it, and most podcast guests have found themselves advocating that. So hopefully we'll drag more and more towards it, and we can engage in further chats around these topics in the future. But again, thank you very much.
Cheers, Jack.
And that was session 22. Huge thanks, of course, to Roger for his time, but also for agreeing to bravely delve into what was an awkward topic. Here at Physio Matters, we try to vary our topics, questions and delivery styles as much as possible, while staying true to the values that have driven our seeming popularity. When our statistics are intermittently analysed and feedback's collated, I can't help but be intrigued by the clear spike in listeners that occurs when we cover a more independent or more discrete entity. So core stability, tendinopathy and shoulder instability are examples of podcasts that attract an extra couple of thousand listeners than, say, Does Work Matter or The Psychology in Physio. And I could include this episode in that, I propose. So feedback regarding all of these episodes is equally positive. And having been present at all of them, I can confidently say that the level of expertise and ability to deliver it is consistently high. And so I would say as a profession, we still at least seem to crave a little spoon feeding. So I hope this episode raises a few eyebrows and pushes open a few rusty hinged doors of philosophical pondering in most of you. Because as an educational platform, Physio Matters has failed if it only helps you to become a better physio or other MSK professional. It only truly succeeds if it helps you to become a better thinker and therefore person. So thanks for listening. You've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Bye for now.